We will be breaking for the summer, and this is our last webinar prior to the summer. So we'll go ahead and just go through a few introductory slides, and then I'll get to the topic for today, which I'm really excited about. It's a topic, a lot of growing interest in this topic that we have for today, certainly a developing interest of mine and many others, and I think really an opportunity for many of us to learn together. So as always, for those of you who have been joining us regularly, and for those of you who are new, our Choosing Wisely in Pediatrics community of practice is really about fostering knowledge sharing and collaborative learning to promote high quality value added care by focusing on the overutilization of certain tests and therapies. We launched in 2019, and we're really growing our reach and even starting to grow our reach south of the border. And certainly as I and others are expanding this work, it has been great to collaborate with others throughout the world, and delighted to have someone join us. One of our speakers today is presenting from the US. And we've held several webinars to date with many different topics of presentation that really are focusing on topics related to acute care centers, but really all centers that are caring for children, but really want to continue to expand that into really anyone and anywhere that is caring for children. Next slide. So just as always, this is a sort of a geographical representation, but certainly continues to grow our community of practice, and really want to ensure that we are reaching from coast to coast, north and south, and really, again, trying to build a representation from all areas, recognizing that children are seen in many different settings throughout our country. Next slide. And these are just some of the topics, again, for those of you who are new, that we have been speaking about to date, a lot of areas related to overuse and opportunities for de-implementation. Next slide, please. And we're moving the needle one step further. Over the last several months, a group of us that have been part of this community of practice have been separately meeting to develop a first national Choosing Wisely bronchiolitis toolkit. It's a pan-Canadian group of pediatric hospitalists, pediatric emergency physicians, family medicine, and family partners that are working on developing a toolkit through Choosing Wisely Canada and through the support of Choosing Wisely Canada. It's going to have two phases. The first one, hopefully to be released this fall in time for bronchiolitis season, that is outpatient and emergency room focused. And then the second one will be more inpatient focused, and will include, like all toolkits, a local measurement strategy to really try to move the needle in this work from just knowledge sharing, collaborating learning to implementation, dissemination, and impact. Next slide. As always, our resources, we partner with Children's Healthcare Canada, their health hub, where all of our resources are provided. So if you have an interest, if you missed a prior talk, a lot of our resources are shared here, including recordings of our past webinars. Next slide. And we always are looking for more topics and more areas of interest in this space. So if you have any, please reach out to Lauren and or myself. We're always looking to hear about work that's being done in this space. And so please connect with us as we plan to have our next webinar to reconvene in the fall. Next slide. And so without further ado, I want to get it going on our topic for today, which is really talking about planetary health and the linkage with planetary health in resource stewardship and addressing overuse. And so we are joined by two fabulous speakers, and intentionally wanted to just have two today, trialing this so that we have a little more opportunities for dialogue at the end. Really want to open this up at the end, if you're able to turn your camera on, to engage in some dialogue around this topic. Because I think there's more for us to learn and new information to seek out than we actually understand in this area. And so I think there's a lot of opportunity to learn from each other. So I encourage you, as always, to think about your questions so we can have those at the end. So I'm going to introduce both of our speakers, and then we will get going. Let me see if we have any more slides. Lauren, I think, as always, And I guess, yeah, I should have said this at the beginning that, part of Planetary Health and focusing on our environmental sustainability aligns with choosing wisely Canada's strategic plan, and really is a pillar of their strategic plan. And a lot of work, Wendy Levinson and others are really doing a lot of work in this space. And much more to come. And it really was showcased at the Choosing Wisely Canada National Conference this past May. Next slide. Okay, so we're going to go ahead and get started. As I mentioned, just feel free to put your questions in the chat, and we'll get to those at the end, or on mic, and we can ask your questions at the end. So I'm going to introduce both of our speakers now. We're going to have Dr. Samantha House start first, and then followed by Dr. Katie Gardner. So Dr. Samantha House, I'm delighted to have join us today. She's an associate professor of pediatrics at the Geisel School of Medicine at Dartmouth, where she serves as a section chief of pediatric hospital medicine and the vice chair for quality. Sam's research interests surrounding the measurement and reduction. Research interests include surrounding the measurement and reduction of low-value care in the pediatric hospital setting. I had the pleasure of meeting Sam at PAS this year and hearing her speak, and just wanted to pin her down and had tons of questions for her at the end. So I'm delighted that are able to join us today to engage in this conversation further. And then next, we have Dr. Katie Gardner, who's a pediatric emergency physician at IWK Health in Halifax, Nova Scotia. Katie serves as the Director of Quality and Patient Safety for the Division of Pediatric Emergency Medicine. She completed her residency training at University of Calgary and PEM subspecialty training at Dalhousie, as well as the EQUIP Certificate Course and Improvement Fellowship with the Center for Quality Improvement and Patient Safety at University of Toronto, which is where my path overlapped with Katie, and we've been able to work together the last few years. And Katie's improvement interests include resource stewardship, patient flow in the ED, and environmental sustainability, and has certainly taught me a lot about this topic over the last year. So welcome both to our fabulous speakers, and I'll hand it over to Dr. House to get us started.
Yeah, thanks so much. I'm really excited to be here and so glad that we met at PAS. That's a nice reminder of what the potential is to meet people in person at meetings. And so it's great for me to be here connecting with like-minded people. I don't have any formal disclosures, but just want to give the caveat that this is a new area of interest for me. And so we were joking a little bit before everybody joined the call that I hope the questions aren't too hard. And there may be people on the call who have sort of more knowledge on this topic than I do, but I've developed a recent interest in really thinking about this linkage between choosing wisely or de-implementing low-value care and planetary health. And I think it goes without saying that this is a critical issue for kids. So not only does the care that we render to children influence the planet, but it's those children who need to continue to live on the planet and will feel the impacts of any decisions that we make now that influence the environment. So I think this is really a critical area for us to think about as pediatric healthcare providers. Next slide. And I just wanted to share a little bit about me before we get into the meat of the talk, just to give some foundation on how I became interested in this, partially because, I think a lot of people think about these issues and say, that's really complex. I don't have training in that particular area. And that's absolutely me. And I think we need all hands on deck as we try to address this issue. So I live not too far from some of you in relatively northern New Hampshire and work at Dartmouth, right on the border between New Hampshire and Vermont. And this is a beautiful fall photo of our undergraduate campus, where before I went to medical school, I had an opportunity to complete an MPH. And Dartmouth's MPH program is really focused, has sort of made a name for itself in looking at variation in care delivery, and in particular, supply sensitive care and sort of overuse of health services. So I feel like I had exposure to those concepts before I really even formally entered medicine. And that certainly shaped my career moving forward. Next slide. I came to Dartmouth for pediatric residency and then stayed on as faculty and have been here since that time, and also had the opportunity to have really great mentorship with people also very interested in thinking about choosing wisely and reducing low-value care. And so I started my work looking at low-value care and bronchiolitis, popular area of focus, I'm sure, for many on the call. and had, again, really strong mentorship there. But I came to decide along the way that we really were struggling to identify what a big problem low value care was, because we didn't have very good ways of measuring it. And so our tendency was to look at low value care within a particular condition and think about how we could structure de-implementation projects within a particular condition. But I noted that we really didn't have a good sense of what was happening across conditions, and thought there may be some areas of low value care that were sort of under-resourced given the impact that they might have across children's health. And so I've actually spent the last few years working with the Children's Hospital Association to develop a calculator that's used to measure low value services. And this is a publication that describes how we created that calculator and what's included in that calculator. I'm not going to talk a lot about the specifics of the calculator today, but it's here if you want to take a look at it. And what's been really interesting for me, this tool was designed both as a quality improvement tool intended to be accessible to clinicians who participate in the FIS database to actually look at their own data and look at comparative data, but also as a research tool so we could answer sort of big picture questions about low value care. And what's been interesting to me is kind of taking this tool on the road and hearing people's responses to it. And I spend a lot of my professional time in circles like this one, where stewardship is sort of on the front of our brain, and we're really thinking about the impact of overuse of healthcare services. But of course, that's not everybody's primary priority. And so as I took this tool into a variety of different departments at children's hospitals across our country primarily, it was often the case that I would have 2 or 3 people sort of leading the charge and saying, hey, we really want to implement this tool. We really want this to be an area of focus. And then I would almost inevitably have a group of people who said, this isn't a big enough problem, right? So I get it. You don't want me to use albuterol for bronchiolitis, but I might get sued if I don't use it. And if I don't get this chest x-ray, I may miss a pneumonia, and that's going to be really problematic for me down the line. And there's just all kinds of other things that are influencing child health right now that this isn't my primary priority. And that was eye-opening for me, again, particularly because I spend a lot of time talking to people who have similar interests. And so it was really helpful for me to hear that perspective. Next slide. All of that said, I think we've made relatively good traction on getting our sort of pediatric community invested and really thinking about the issue of low value care through our historical focus on 2 issues, which are really cost and harm. And as we talk about cost, we think about cost to the healthcare system, but we also think about cost to individual patients and families. There's sort of an increasing body of literature on the latter, cost to individuals, which I think sometimes we'll get a little more buy-in than thinking about what a particular service costs our system. And then we also focus on harm. And as physicians, I think harm is really where you get people's interest, right? What happens when we give unnecessary antibiotics or unnecessary imaging or sort of other things that we could avoid? What are the harms to the patients? So I think this focus has drawn in a good amount of people and attention over the past decade or so. Next slide. But we've recently faced, the word is unprecedented, right? That's what we've used to describe what we've seen over the last 5 years, sort of an unprecedented number of disruptions in child healthcare. And so this slide really just represents, we dealt with a pandemic, we dealt with a worsening mental health crisis coincident to and subsequent to the pandemic. And then over the course of the last winter, we dealt with a tremendous respiratory surge, unlike what most of us have seen during our careers. And so there's been a lot of different areas of focus, and people, I think, have struggled with thinking about how they spend their bandwidth and what issues really warrant attention and sort of active efforts. And next slide. And so as we sort of start to come back to conversations about low value care, I don't want to say that they stopped during the pandemic and the subsequent years, but again, we just had a lot of things to focus on. I think there's new implications that are coming to light that we can use as sort of hooks and as really important areas to consider when we think about the impact of really trying to practice high value care. And this is a short list that's not complete. I'm sure folks on the call could add other components here, but these are some things that I've been thinking specifically about as we've kind of reinvigorated discussions in this direction. So first of all, COVID effects. The pandemic itself has led to some interesting changes in healthcare utilization, including the resurgence of some services that we had worked really hard to eradicate or minimize previously. Some examples of that are respiratory testing for viral illnesses. We've seen an increase in steroid use for bronchiolitis again. So I think there's a need to kind of measure that impact and think about how we can make improvements in those areas again. We're seeing increased financial strain. So as we consider cost, a lot of our healthcare systems are under more strain than they've seen historically, with a lot of hospitals reporting negative margins and kind of anticipating weathering those margins for a period of time. So to some extent, I think the financial piece becomes a bigger consideration in today's landscape. We've also seen new types of resource constraints. So you all likely experienced over the course of the winter times when you maybe couldn't get amoxicillin or ibuprofen or albuterol or some of the things that we consider to be really core to our healthcare delivery mission. There's an interesting article in JAMA last week that really just was a bit of a warning in that those constraints were directly related to supply chain issues from the pandemic, but also reveal vulnerabilities in our system that suggest that we will continue to face constraints along the way. And I think historically we've sort of, pardon me, but particularly here in the US, practiced in a way that sort of indicates that we have unlimited access to any resource that we want. And it is becoming clear that that is in fact not the case. There's some really interesting new conversation around choosing wisely and health equity. So it's clear that we don't really know the impact of low value care on different populations, and understanding that is going to be really important to thinking about how we might prioritize de-implementation. So if there's a particular service that's of very low value that is being given more frequently to patients in marginalized populations or those who may already have worse healthcare outcomes, then directing resources there may help us to improve health equity. So a lot of sort of investment in that space. And then finally, what we're really here to talk about today is climate. So there are emerging discussions about the positive impact we could have on planetary health, with a lot of attention to this issue of low value care. And we'll spend a little bit more time talking about that today. Next slide. So a little more about me. This is a picture of a ski area that's about 10 minutes down the road from my house. It's called Whaleback Mountain, and it's a nonprofit, and I sit on the board of trustees for Whaleback. And these are my kids learning how to ski at Whaleback and then being a little bigger and skiing at Whaleback. And so this mountain has been a really important part of my life outside of medicine over the last 20 years. And New Hampshire and all of New England and much of Canada historically have been dotted with all these great little ski areas where communities can go and gather and get outside and get fresh air during the winter, and enjoy an affordable outdoor recreation experience. Over the last 2 decades, these types of ski areas have essentially been completely eradicated. So it is very atypical to have a ski area like we do with a chairlift so close to our house that's so small. And the reason is because the snowmaking window has been reduced to such an extent related to global warming that producing enough snow to keep a mountain like this open and keep rates affordable has become basically a non-starter. So this particular ski area and my involvement was actually the first reason I became interested in climate before I even started to think about its relationship to low value care. But I think it's a nice example of a really tangible change that our children and future generations are going to experience as we continue to see climate change. And again, hopefully ties it back nicely to the issue of child health and what planetary changes do to our communities. Next slide. So at work, I became interested in planetary health as I, again, started to kind of read some of the emerging literature around what we could do by focusing on low value care and how we could help climate. We also had a Grand Round speaker come a couple of years ago from Emory, whose name was Rebecca Phillips-Bourne, and she shared this with our group. If the US healthcare system was a country, it would be ranked 13th in the world in greenhouse gas emissions. So that was really eye-opening to me. I understood that our country wasn't doing particularly well in terms of climate impact, but this really helped me to visualize the extent of impact that our healthcare system was having. Next slide. And so in preparation for today's talk, I assumed that you all were doing significantly better. And so I spent some time digging into the literature, and it turns out that I'm wrong. So about 5% of Canada's carbon footprint is coming from healthcare. That's as compared to 10% of the United States. And so you got us beat there. But Canada is in the top 10 countries among sort of comparable countries in the world in terms of healthcare emissions per capita. And, there's a lot of talk amongst the UK and New Zealand and Australia around a lot of tangible steps that their healthcare systems have taken to really start to change this trajectory. And I think we're behind. And I think the US is behind Canada. And I know that both of our countries have made some steps and are starting to really pay attention to this, but I do feel like we're behind many areas throughout the world in focusing on this issue. Next slide. So this is a nice visual, I think, that comes from a research group in Australia. And I will say, I think the Australians have done the most work to really help us to understand the numbers here, to try to quantify how much high-value healthcare could positively influence the climate. And so this was a helpful visual for me to take a look at. So on the pie chart here, you see both blue and gray, and the blue represents sort of estimated emissions related directly to clinical care. So these are emissions related to the decisions that we make every day for our patients. The gray represents emissions related to buildings and electricity and gas. And there certainly is, when we talk about climate, we talk about scopes 1 and scopes 2 and scopes 3. And I have a slide on that, but I think it's probably it will take too long for us for today. But these are all different types of input that we think about when we consider carbon emissions. 2 out of the 3 scopes are indirect. And so there is a lot of indirect input here, including in the clinical care aspect. So this means you may make a decision to give somebody an albuterol inhaler, but that albuterol inhaler had to be made somewhere and had to get shipped to the bedside. So the 80% bucket considers all of that as part of clinical care. But I found this to be relatively eye-opening because I think I would have assumed that just the buildings and the electricity and the gas accounted for more of the carbon emissions. And so, those feel like things we can't directly influence as clinicians as much as we can the clinical care. And it turns out that the clinical care really is a big piece of this pie. Over on the right, you can see this broken down in terms of estimates of how helpful the care that's being delivered is. And this is taken from a whole bunch of data sources, and I think it's appropriate to say that this is an estimate, but these estimates align with those that we've seen published in healthcare literature previously that suggest that about 30% of clinical care may be wasteful. This particular author group goes ahead and says that 10% of clinical care that's delivered may be overtly harmful, and then about 60% is effective. So in this article, they really start to talk about, what things would look like if we were able to reduce that 40% that are in the yellow and red. Next slide. And this, we can just skip by this one. So a couple of take-homes from that particular work in Australia. They also found that hospitals and pharmaceuticals represent a majority of healthcare emissions. This is probably not super surprising, but I think many people on the call are probably hospital-based, and so there is a lot of improvement to be made in our settings. I mentioned this issue of sort of what's under the direct influence of healthcare versus what's indirect, and a lot is indirect, stemming from what we call the goods and services of patient care. So again, it's not just the one particular lab draw that you do at the bedside that contributes to the carbon emissions, but it's the reagent getting to your hospital from someplace across the globe to be administered to the patient. And all of that needs to be considered. And then in this article, they said low value care reduction could save 10,000 kilotons of carbon CO2 emissions. I don't know what that means in my head, right? Because I'm not a climate scientist. And so one of the things that's nice is that there are a bunch of online calculators you can use that tell you, like, okay, if I think about this number in emissions, what does that mean in terms of day-to-day use? And so I think I put, Lauren, if you go to the next, you just push ahead. I put the equivalent, which is over 2 million gasoline-powered passenger vehicles driven for 1 year. So, I think as a clinician, I feel like it's important for me to admit that these numbers are hard for me to understand and require sort of a lot of mental energy for me to dig in. But I think the more that we start to talk about these numbers and quantify the impact of the services that we're using, the more we can make this a part of the high value care conversation. So I think we need to be taking those steps to familiarize people with this impact. Next slide. And so this is what I mentioned. I do think we need to start measuring more often and really trying to come up with sort of numbers on how much we can help the environment if we focus in here. The classic way to do this is what's called a life cycle assessment, or an LCA, which is described as the systematic analysis of the potential impacts of products or services during their entire life cycle. It is hard to do a life cycle assessment, and I think it really requires a lot of collaboration with colleagues who know what they're doing in this space. And that's what we've started to do here at my institution, is really work across campus to say, how can we partner with the engineering school and with other folks who might have time that's protected to do this type of work, to think about these analyses in healthcare. Next slide. This is just sort of a visual of what goes into a life cycle assessment. I've already kind of alluded to this, but it really is sort of start to finish the whole process of giving someone a good or service. Next slide. And then there are people who are doing good work in this space, and I think we need to look to them as leaders of the profession. This is a really nice website and organization. So Wiser Healthcare, which is an Australian organization focused on reducing overdiagnosis and overtreatment, has a section of their website that's called Wiser Carbon Neutral, that really summarizes the literature that's out there on low value care and planetary health, and on the life cycle assessments that have been done by these groups and groups that they know of, at least. And it's a great place to look and just sort of see what's out there in terms of literature. It is still pretty narrow, but I think some great examples of study designs that we could make tangible as healthcare researchers. Next slide. This is an example of one of those. So this author group did basically a life cycle assessment to look at the carbon footprint of 5 common laboratory tests. And again, tried to display results in a way that were tangible, and said this output is equivalent to these day-to-day activities. And so I hope we'll see more of this popping up in the medical literature. And certainly my intent is to begin to do some of this work for the measures that are included in the low value care calculator, which I mentioned earlier. Next slide. And I think we've already touched on this, right? So considering the environmental impact as an outcome of the care we deliver is really key. And then I mentioned how collaboration can, I think, help to move this work forward. And I'm probably relatively close on time, so I won't spend a ton of time here, but I'll just mention that as we've tried to implement this calculator, it's become really clear to us that we need to think about the impact of all of these services on multiple fronts. We need to think about how many kids they're impacting. We need to think about the proportion of encounters that they're impacting for a particular diagnosis or a particular service. We need to think about physical costs associated with these services. We're starting to look at how they impact equity. And my vision is that we will have sort of a scorecard that has a column that includes planetary health as one of the potential impacts of each of these services, so that a clinician can look at your scorecard and say, okay, of all of these things, I want to work on X, Y, or Z because they're having this level of influence in this area. And I think historically we've been very narrow in our focus, but it's clear to me that there's a lot more impact of these types of services than we've, I think, historically focused on. Next slide. Yeah, I mentioned that. I think that's it. Thanks everyone for listening. I hope we can have some good conversations at the end, and I'm sure you all have a lot to teach me.
Thanks so much, Sam. Really appreciate it. I'm going to go ahead and hand it over to Katie.
Hi, everybody. Thank you so much for having me. I'm also not a climate expert, but I think that was a really nice summary of how, as clinicians, we're probably all concerned citizens and wondering how we can make an impact. And I've been doing some work towards starting a QI project on sustainable asthma care in pediatrics, and specifically in the acute care setting in the emergency department. So I thought I would just talk a little bit through that. And I think, you know, when we start to learn about healthcare impact on climate change, it can feel kind of big and daunting, because a lot of the areas where we need to make big impact, as you heard, are from areas like the supply chain and facilities and things that maybe in your day-to-day clinical care you don't have a lot of control over. We can probably lend our voice to advocating. But for me, I saw an article a couple of years ago about how asthma treatment is actually really having a negative impact on the environment. And that, to me, kind of struck me as that's something that I do on a day-to-day basis. I prescribe medications for asthma, and can I be making a change in my practice? And so kind of led me down this path and trying to look at it from a QI lens. You can go to the next slide. And so what I want people to kind of answer these questions for me, because we're just heading down this path of starting this QI project, and I'm really interested to hear if anyone in this community has been addressing this in your practice for pediatric patients specifically, and what's your experience with dry powder inhalers in children, because there's been a lot of heavy lifting and work done in primary care, and a lot of great resources out there, but it still feels like there's a bit of a gap where it's a little unclear what we should be doing on the pediatric side. But I'll talk through some of the opportunities. Next slide. So if you want to pop some thoughts in the chat about those questions as we go, or we can discuss at the end. But the crux of the problem is that the treatment for asthma, as you all know, is for the most part meter dose inhalers. And as it turns out, the propellants in these devices, the hydrofluorocarbons that are used to get the medication out of the device, have really high global warming potential. And so, as opposed to a lot of other consumables where the production of the product is the biggest impact, in this case, the use phase and the disposal of these devices because of the propellants is where a lot of the carbon footprint comes from. And a single Ventolin MDI is equivalent to about a 290-kilometer journey in a gas-powered car. So if you're using many of these over the span of a year, you can have a big impact on the environment. And so you can see this poster is directed at primary care. There are green inhaler options, but what does this mean for pediatrics? Next slide, please. And so when I'm coming at this is a nice article for clinicians on how you can address sustainability in your practice, and thinking about kind of 4 big buckets, and I'll kind of go through all of these in terms of where there are opportunities in asthma care. Next slide. So the first step is really prevention, and for me, we may not be able to directly prevent children from developing asthma, but we can prevent poor control of asthma, and we can prevent acute exacerbations through different avenues. So ensuring that children get an early appropriate diagnosis, and that will help to avoid treatment delays, reduce morbidity, maximize lung function, and as an environmental co-benefit, you're going to use less rescue inhaler over your lifetime if your asthma is diagnosed and well controlled. So you're going to use less of those MDI devices year over year. And as we know, in children, it can be a little bit challenging in young children, but the Canadian Pediatric Society and Canadian Thoracic Society have come to a consensus on the clinical diagnosis. And so we should be making this diagnosis early when we can document airflow obstruction and document reversibility, and there's no signs of alternative diagnoses. Patients and families benefit from a written management plan that's shown to have better outcomes for their disease control. And so we can provide that from the emergency department. I think we could be doing a better job from an emerge standpoint. That's probably better done by my community colleagues and specialists. But the other thing that's a bit of a challenge in the emergency department is appropriate prescribing of inhaled corticosteroids. And what I mean is that a lot of my colleagues, I think, see chronic disease management as not as the emerge not having a role there, but really our guidelines would say we should be prescribing for patients. We tend to have the opportunity because we see patients during their first presentation a lot of the times, or their first acute, like moderate or severe exacerbation, and they should be on an inhaled corticosteroid. And that's to our benefit too, to prevent their future visits to our department. So, so opportunities just in the realm of prevention. Next slide, please. In terms of acute asthma management, and especially among this audience, if you're working in your personal practice or working on projects to reduce low value care, then you're already, and as you heard from Sam, already doing work towards sustainability. But we know that patients have better outcomes when we use clinical order sets or pre-printed order sets. It helps standardize care and provide care that's evidence-based, based on PRAM scores, so severity of symptoms. And we can also avoid overuse within the emergency department, so not giving systemic steroids to those who have mild exacerbations, and avoiding use of Atrovent in patients who are not in the midst of a severe exacerbation. Nursing care directives are also beneficial. We can reduce the door to steroid time by having the nurses give steroids as soon as they recognize an asthma exacerbation, not waiting for the physician. That reduces their length of stay, but also reduces the frequency of salbutamol that a patient gets. And so they'll have less side effects. It's better for the patient, but also obviously we're going to use less of that propellant over time by not giving it so frequently. And then eliminating low value care like x-rays and antibiotics. A lot of people in this community are already working on that. Anytime you do less of something, as you heard, you're going to have an environmental benefit. Next slide. And so I think the question for me has remained, so what can we do in terms of low carbon alternatives for asthma management? And there's sort of 3 buckets that we're going to go through. Next slide. The big focus in primary care has been on making the switch to dry powder inhalers whenever possible. And so obviously in young children, this is going to be a challenge. So for the majority of our patients in the ED anyway are in that sort of under 6 age group, and they are not going to be able to generate the inspiratory flow needed to use a dry powder inhaler. So then the question becomes, at what age can you use them? And I would say that there isn't really agreement among the circles that I've been talking to. I think we can safely say 12 and up. So adolescents and adults can use, for the most part, can all use dry powder inhalers. Obviously, there's still some individual discussion that needs to happen. If you've got muscular weakness or something else that prevents you from using it. But then as we get younger, who can use it? And the, Health Canada would say 6 and up. I would say my colleagues in respirology feel a bit nervous about going that young. So there's somewhere in that spectrum from 6 to 12 where we could probably start to prescribe dry powder inhalers. And what it comes down to is, do we have time to teach proper technique? Do we have ability to follow up with the patient? So we're thinking about, even just for providing better overall asthma care, can we provide sort of an urgent follow-up within 48 hours of their visit to go over everything, but including technique for using their inhalers? We really want specialists from our colleagues. So, so we're going to start a bit old in the 12-year-old age group as an option, and then sort of see about developing a tool at the bedside for assessing readiness to use a dry powder inhaler and kind of move from there. And then cost is always an important consideration. So this poster on the right is from Cascades Canada. And as you can see, if you wanted to stick with the same drug, Ventolin, MDI to a Ventolin discus, it's much more expensive, and it's not covered under provincial pharmacare programs. So probably the better choice would be Bricanyl from a cost point of view, but then you're switching drugs. So we want to make sure that the efficacy will be equivalent. So things that we need to sort of agree with our specialist colleagues about. But as you can see, there's lots of options, and many that would be covered under pharmacare programs. So that's what all those green check marks are, is what's covered. Next slide. A quick change that you can make in your practice today is to change the choice of inhaled corticosteroid. And I know practice varies on this. As I touched on, for me in my practice, patients who are coming with moderate or severe exacerbations should automatically be on an inhaled corticosteroid. So there's some work to do on making sure that people are prescribing it in the first place. Next slide. But you can also choose a less impactful device. So in my local group, what I would say is that the vast majority of people are prescribing fluticasone or Flovent. That's been the preferred choice for a long time. I think that comes from, there was the most literature around fluticasone in young children, and it's a cheap option. So most people in my group are prescribing the 50 mics per inhalation, 2 puffs twice a day. And if you look on the right-hand side of this chart, you can see it's the highest impact in terms of carbon footprint. So there's the grams of CO2 equivalents, which is hard, as you heard, for people to wrap their head around, but equates to about almost 1,000-kilometer car journey in a gas-powered car. So, and then if we go down the route, if you just wanted to make a really easy switch, if you want to stay in the medium dose range, you could go to a 125, just do 1 puff twice a day. It's actually cheaper, and you've cut your carbon footprint in half on a yearly basis. But even better from a environmental impact is the glycinide or Aldesco. It is a lot more expensive, so you have to kind of have that conversation with each of your patients, but it's also once a day, which is why the impact is that much less, because less actuations of the device. And then, so I feel like for a lot of families, this is easier to comply with, so they might prefer that anyway, as long as they have the drug plan or the pharmacare plan to cover it. And then QVAR kind of sits somewhere in the middle. It's similar cost to Flovent, and kind of in the middle in terms of impact. So lots of choices that would have lower impact and still equivalent in terms of efficacy for families. And we have some choices that are still low cost. Next slide, please. So in my institution, we have this asthma action plan and discharge pre-printed handout. This is adapted from CHIO, so you may recognize it. But as you can see, for us, we only have Flovent as a pre-printed option there. So of course, people are going to gravitate to prescribing that. So one of the things we'll do is change this to have other choices, and then create the prescribing tools based on that chart, so that it's easy for people to make a different choice and make sure that they're choosing the right dose based on the presentation. Next slide. And then something that's still sort of a question mark, but is, can we change our practice around Atrovent? So good evidence that Atrovent improves outcomes in severe asthma exacerbations. We can deliver it by meter dose inhaler or a nebulizer. There was a big body of work that was done kind of 10 years ago-ish to have people switch their practice from using nebulized Ventolin to nebulized or to MDIs, both at home for treatment of asthma and in the emergency department. And so I wouldn't be advocating for completely changing our practice, but can we safely, just in the really focused initial stabilization of the patient, when we're giving the initial Atrovent and Ventolin, could we safely do that by nebulizer instead of meter dose inhaler, and then do the rest of the Ventolin by MDI? And the outcomes that they've generally looked at, the clinical outcomes, are things like hospital admission, ED length of stay, and then side effects. And so those would sort of be our balancing measures in terms of, are we negatively impacting that? And it would be important to think about workflow and nursing preferences and how it impacts their workload as well. So this is still something we need to take a deep dive into the literature and sort of test out and understand people's sort of barriers to doing this. I have heard of, I don't think anywhere in Canada, but in other countries, maybe resource poor settings, reusing MDIs between patients. I don't think this would ever fly from an infection prevention and control point of view. So I don't think that that's a viable option, but the reality is that we throw out that MDI after that sort of single use. There's lots of medication left in the device and lots of propellant. So it feels kind of like a big waste and a big cost. Next slide, please. And finally, just to touch on disposal, I think there's some awareness building, but a lot of people don't know that in order to properly dispose of the leftover propellant in the device, it has to be incinerated at a high temperature. And even when I do a casual ask around to my staff, I ask the nurses, like, what do you do with the MDIs? They just toss them in the garbage, and nobody has really educated them on the fact that they need to be incinerated. I even had one nurse say, well, no, it'll blow up and it's really dangerous, so you don't want to put it in the incinerator. But within my institution, if you do put it in the medication waste buckets, it will be incinerated. So it's more education. And then in the community, educating patients and families about taking their MDIs back to pharmacies. In BC, Manitoba, and Ontario, and Prince Edward Island, the producers are mandated to have their medications and devices and sharps properly disposed of. And so they pay into a program that organizes a pharmacy take back program. So a lot of pharmacies will take back those devices. And so that's an option. And if you're outside those provinces, a lot of pharmacies still will take these back and make sure that they're incinerated. So just have to ask those questions. And a lot of these resources are from Cascades Canada, and really encourage you to look at their website. They've got great resources on climate conscious prescribing and lots of educational resources. And so that's the end of my slides. I think one more slide, but yeah, as we get going, I'd love to hear if other people are working on this from the PEDS point of view and what your experiences are.
Fantastic. Thank you so much, Katie. Both Dr. House, Dr. Gardner, excellent talks, and really, I think, generate a lot of ideas. I'm sitting here writing down sort of a mini list, and certainly hope to see it grow. But I want to open this up for comments and questions, and I think we already have a few. And if you're comfortable turning your camera on, and maybe we'll stop sharing the slides just so that we can all sort of make it easier to talk. There's a first question that I see here that I think, Katie, would be directed for you. It's with respect to MDIs. During COVID, we shifted even more to MDIs to avoid AGM procedures, such as nebulizers would be. What is the balance from a risk-benefit perspective? So I think related to whether there's a need, your adjuvant.
Yeah, I think it's an important consideration. I think we have to work with our infection control team to make sure that that's considered. I would say we're using nebulized medication again in other settings like croup. We're using epinephrine. We don't have access to the metered dose inhaler anymore. So we know that it's a risk, although I'm not aware of truly like transmission to our staff from the nebulized medications, even though it's listed as an AGMP. But I think are really something that we will consult with our IPAC colleagues as we kind of think about whether we can make this change.
I'm going to ask that question. I think it's kind of important because with the new guidelines with the pandemic, if you did do an AGMP, you got to put on an N95 mask, you got to put on a gown. That's like a lot more waste involved with these new guidelines. And at least in my facility, people are using them, but nobody ever said to not do those anymore, because we were a nebulized hospital, but when COVID came, we all switched to MDIs for everything. And then nobody's ever said, you should switch back because, it's still considered an AGMP and you're still supposed to do these things for all AGMPs. And I'm not sure if anybody's ever said to stop doing that. So it's a kind of a risk benefit analysis because knowing what you're sharing, which is really important. And, we used nebulizers for years and years and years, didn't really have a problem. And it was just with the pandemic that the pendulum swung very far. And, we still don't use inhaled epi unless we really have to, which is different than how we may have used it before. So it's a bit of a conundrum. And as you said, like the pandemic really did increase probably our carbon footprint in some ways. Of course, when everybody was isolated, carbon emissions went down because everybody was staying at home. But for that aspect, and I hadn't really thought of it until just recently about the MDIs. So I think it's very interesting, but that is a bit of a conundrum for some, and how you make change and manage that with those competing interests.
Yeah, for sure. So I think, like Olivia pointed out, it's probably about first reducing use overall of Atrovent when it's really not needed. And then I would be consulting with IPAC about where we stand on, because I think what's written in our guidelines and what we're doing in practice, I would admit, is different anyway in terms of what people are wanting to do nebulized medication. So I think it's time to circle back with the experts and say, like, what are the current guidelines that we should be following?
And the other thing you can do with MDIs is if you take the plastic part and either sterilize it or had multiples of it, the canister itself would have minimal infectious risk. And I know places where they do that, they just rotate the canister and sterilize the blue part. Like let's say a Ventolin.
It's a advocacy piece for the producers because they always package them with the plastic the holder for the canister. So if they were willing to just send the canister and we could reuse the outside bit, that would help, although the big impact is from the propellant itself.
Right, but then you're not throwing away ones that you only use 10 puffs out of.
Yeah, exactly.
And actually, if you could advocate for counters on the ones that don't have counters, that might also help, because the labs have counters on them. And, if you could have counters on Ventolin, it would help everybody. I know at sick kids, they have to have, like, it's almost like narcotics. They had to count off all their puffs of Ventolin, because otherwise you might be using an empty Ventolin inhaler and not know it, because they will use the same Ventolin inhaler on a ward. I don't know how it's done, but yeah.
Great. Thanks for that. Those questions and comments, Sarah. Claire, I see your hand up.
Hi, just really fast. One of my jobs is to sit in the asthma clinic here at BC Children's Hospital, so I have to run off to clinic and do that. But Katie, if you want to email me, we did a lot of QI stuff in our emergency department about 5 years ago to try and reduce and improve. And we just, in general, as a concept, as a group, have looked at all the data for MDIs. They're terrifying when you look at the number of car journeys and everything like that. But actually, if you look at the tables when you compare an MDI versus a DPI, it's definitely less, but it's actually not as good. It's definitely the best is to not need it at all. So actually, our overall carbon footprint, we as a group have decided, is to actually really target prevention. And so I love the fact that you started with prevention, because people get a little bit distracted just talking about car mileage. And actually, if I can stop, so I've had kids who've been into the emergency department 5 times because nobody told them how to take a puffer and they didn't know they needed to be on a regular puffer. So for example, Flovent 50, 2 puffs BID, I never prescribe because it runs out after a month. So it's more expensive. They come back into the emerge because they're using an empty puffer. And so those sort of practical things, I think it's really important to look at a bigger concept. MDIs versus nebulizers, we know that there's good evidence that if you use MDIs in the emergency department, your length of stay is shorter and they have less revisit times because they know how to practice and use it, and they don't think they have to come to the emergency department for the nebulizer. So it's not kind of complete straightforward. And I think actually going back, bread and butter asthma is very simple and doing it really well. In our perspective, we've decided that that's what we're going to do. The other thing I'm going to try and do here is not use 60 or 30 doses for some of our canisters here. So they only use 30 doses for some of our Ventolin and 60 doses for some of the ICSs. And if we can swap that and then the family take it home, that will actually have the number of MDIs that are prescribed. And because so those are big impact from a systems perspective, is to try and change that, as well as your own, making sure people know what they're doing. So that's what we've decided to kind of do here. But I think it's really, 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 really important to talk about. So thank you for this.
And I think there's been a big focus on dry powder inhalers, but as I'm learning more about it, if you look at other impacts other than the carbon dioxide equivalents, dry powder inhalers, there's actually other places where they have big impact. So it's not, yeah, so I totally agree with you. I think there's other avenues where we can make impact and we don't have to worry about trying to get dry powder inhalers into the mix as much. So it's definitely less emphasis for me. Yeah.
Yeah, definitely sounds like there's a lot of low hanging fruit that might not have been as obvious up front, but is truly is there, as you both have nicely illustrated. Seppi.
Thank you very much. I have for these excellent presentations, I've got a question for Samantha. And I was wondering, I mean, the challenge that I feel like we're facing is just accessing big data, accessing big health data, and even hospital data where the infrastructure for some of these things is perhaps doesn't exist in many settings, even in high income countries. And then getting that data and then having the expertise, whether it's local or getting collaborations from national and international bodies, is absolutely essential to actually be able to translate that into putting it into the calculator in the first place. And many times these choosing wisely or reducing low value care, of course, is also associated with reducing the cost of healthcare delivery. And the corollary is that having access to a good health economist who can translate all of this into real terms and then again translate it on a hospital-wide or region-wide or nationwide level. I mean, this is the challenge that certainly we're facing. And I'll give you an example, for example, using saline lock compared to the continuous effusion or the TKO that's commonly practiced in North America. It's at least 2/3 cheaper, and there's a huge potential environmental impact. It's sort of converting to saline lock rather than having continuous infusion. But how do you get that data? I mean, how do you translate it into those real terms to be able to make a difference and then get other people aware of it so they can put it into practice?
Yeah, that's a question that I do not have an answer to, but I'll give you I'll give you some of my immediate responses. First of all, that's sort of exactly the line of thinking we were using when we developed this calculator, because we were hearing from so many people like, yes, I want to be working on asthma, and yes, I want to be working on bronchiolitis, and yes, I want to be working on reducing imaging, but our center does not have the bandwidth to be gathering data for all of those individual conditions, right? And so we pick one and we focus on one because that's what we have the time for. So the intent of this tool, at least for member hospitals, was to be able to provide something that's kind of pre-packaged. It is probably not quite as granular of data as you might like for some of your quality improvement initiatives, but it's there and it's packaged and you have comparative data. Outside of FIS, we've struggled, and I'll tell you, there's a couple, I have looked at applying this calculator in Medicaid, and I'm doing some work on that in the US, and that's a challenge because the amount of data you can get state by state varies, and the granularity of that data is really variable. So there are some of the measures that we can't translate into Medicaid. I think the EMR companies are starting to get smart here, and so I know Epic is really looking at how we can create that sort of big clinical data set that follows patients across hospitals and over time. And I know, there's a lot of work in that space, but ultimately that is going to take time. There's several alternative approaches being proposed specific to low value care. So for example, in adult medicine, many researchers have gone to what's called the indicator approach, where they pick a subset of services that seem to be particularly associated with overall hospital or region performance, and use that as kind of a broader indicator of how your health system is doing comparatively. That being said, that doesn't give you what you need to really be considering climate impact. So it's helpful in thinking about overall performance, but definitely has limitations as we think about planetary health. So those are some initial thoughts. It's a great question. If I had a solution, I'd be perhaps on an island somewhere. but I appreciate it and am thinking about it pretty constantly.
Yeah, for sure. Well, thank you. I'm seeing that we're at the hour, so I want to thank you again to our speakers, Dr. Howes and Dr. Gardner, for joining us today on our National Community Practice webinar. Lots of great discussion and lots of great ideas. I think we could keep this conversation going for sure, and I hope that we can continue it again at a future date, maybe with some other topics of interest as well, where we can connect the two of low value care and planetary health. But I think there's, as Katie nicely said, there's so many more options if we just really think about it, even just thinking about prevention, that I don't think a lot of us initially think about. So thank you again, and happy summer, everyone. And we'll see you again in the fall. And please always send us more suggestions for future webinar topics. Take care. Bye-bye.
Thank you.